Hello and welcome, everyone. Thanks so much for joining us for today's Lunch and Learn event. I'm Ellen Bayer, Senior Editor at Health Affairs. Today's event is being held in conjunction with Health Affairs' Age-Friendly Health Series, sponsored by the John A. Hartford Foundation. We'll be discussing an important achievement of the age-friendly health systems movement, the age-friendly hospital measure, that went into effect in January of this year. We're pleased to welcome Dr. Clifford Coe, who is deeply involved in developing the measure. Dr. Coe is Senior Vice President in the Division of Research and Optimal Patient Care at the American College of Surgeons, which led the development of the age-friendly hospital measure in collaboration with the Institute for Healthcare Improvement and the American College of Emergency Physicians, with support from the John A. Hartford Foundation. In his role at the American College of Surgeons, Dr. Coe oversees quality improvement programs, focusing mainly on surgical quality of care. Dr. Coe has served as an advisor for national and international efforts to improve healthcare quality and safety. Dr. Coe is a double board certified surgeon at the University of California, Los Angeles, where he's the Robert and Kelly Day Professor of Surgery. He also is a professor at Health Services at the UCLA School of Public Health. In conversation with Dr. Coe is Dr. Katherine Ornstein, who's a professor at the Johns Hopkins School of Nursing and director of its Center for Equity and Aging. Dr. Ornstein's work focuses on improving health and healthcare for older adults with serious illness and their caregivers, particularly with respect to advancing equity. She is an expert in home-based care delivery, family and paid caregiving, dementia care, and healthcare delivery at the end of life. We're grateful to Dr. Ornstein for serving as an advisor to Health Affairs for the Age-Friendly Health Series. Following the conversation, we'll have some time for audience questions, and you can submit your questions to Dr. Coe and Dr. Ornstein through the Q&A tab at the bottom of your screen at any time during the conversation. You don't have to wait for the Q&A period. Please do not enter questions in the chat. And with that, I'm pleased to turn it over to Dr. Katherine Ornstein.
Thank you so much, and thanks to Health Affairs for hosting this really important conversation. I want to just get right into this because I have a lot of questions for Dr. Coe, and I think we all do. So before we get into discussion of the age-friendly hospital measure, just for background for everyone, I'd like to know a little bit about the Age-Friendly Health Systems Initiative, which this is part of. Could you just provide a high-level description of the initiative?
Sure. Well, thank you. First of all, thank you to you. Thank you to Health Affairs. So to answer your question, age-friendly health systems focus on I think the easiest way to think about it, and it's really genius to really come up with this, is the 4Ms. And I think that probably everyone on the phone or on the webinar knows, but the 4M stands for what matters: mentation, mobility, and medications. And so these are four really important things when taking care of the older adult that we should focus in on. And I think that the IHI, the Institute for Healthcare Improvement, has done a really great job in kind of prioritizing and having us think about these 4Ms as we take care of these patients in whatever setup or whatever setting we're in. So it's really the 4Ms, and I think, as we'll talk about, the measure really builds on the age-friendly health system work and takes it even further.
Well, with that, Cliff, why don't you go ahead and tell us what this new measure is and really just explain also how it fits into this initiative.
Sure. So, as we were thinking about the measure, and when I say we, it was a whole bunch of really smart people around the table that I worked with and got to learn from. And what we wanted to do is to figure out a way that we could align a policy measure with the things that we should be doing with and for older adults in the hospital setting. And so it took the 4Ms and tried to build on that. So the measure was developed with the American College of Surgeons, and I can talk about how
yeah,
I think why.
Right, that is a good question. Why is the American College of Surgeons involved with this?
Sure. So let me talk about the measure, because that's the most important thing, and then I can talk about how the college got involved. So the measure has 5 domains. The first is goals. So goal setting, shared decision making and so forth. The second is one of the other M's is medication management. The third is frailty screening and interventions. The fourth domain is social vulnerabilities. And so identifying those things, especially as the patient is transitioning from the hospital setting to where they go next, home or another facility. And the fifth is a domain we call age-friendly care leadership. And it's basically the structural components that make up the measure that really it builds the foundation for the other four domains. The college got involved in this because the college has been doing work with the older adults undergoing surgery, the College of Surgeons, for many, many years. And we actually developed a measure just for surgery in older adults. And in doing that, we had 50 different stakeholders and helping us design the measure, develop the measure, test the measure, critique the measure, revise it, and so forth. And we submitted it to CMS. And then we also worked with the Hartford Foundation, who also worked with the IHI and ASEP, the American Society of Emergency Physicians. And we also developed a hospital-based measure for older adults. So we developed two, one just for surgery and one for the hospital. And CMS said, why do we have two of these? Well, let's just put it together. And so it came out to be the age-friendly hospital measure. And it's really those four organizations, the College of Surgeons, IHI, ASEP, and Hartford really helped to organize it and push it forward.
Sounds like a real collective effort to get this together. So what are the major goals of the new measure?
Yeah, I think that it's, the lofty but achievable goal is to ensure that all older adults get ideal, optimal care in things that are really, really important. So these are not just outcome measures, which, I think our system has had outcome measures for decades and it hasn't gotten the care where we want it to be. And a lot of times, it doesn't, outcome measures don't have us focus in on the priorities of care that need to be focused in on, especially in this space with the older adults. So it really focuses on the different domains, the goals, the meds, the frailty, and so forth. And so the goal really is to make sure that these things are being conducted, undertaken for this patient population in a kind of efficient and standardized way.
So I want to unpack a little bit of the measures. And, so you're saying you're not really focused on outcome measures or, so what do you mean in terms of focusing on structural measures? And why is that unique? Like, why did you move in that direction?
Yeah. So it's called a structural measure, but when we designed it and when we think about it, we think about it as a different term. We call it a programmatic measure. However, the form in CMS only has kind of like boxes to check, and so it wasn't an outcome measure, although there are outcome components to it. It's not a process measure, although there are process measures in it. And it's not solely a structural measure, even though they're structural. It's kind of the whole Donna Beedian composite of structure, process, and outcomes. And so we think of it more programmatically, that it's a whole composite that is focused on older adults. So it's not just structural. So in the measure, it's kind of all three things, but really probably the unique part about it, because we have a lot of outcome measures, we have a lot of process measures. The unique part about it is structural, and I think CMS said, "Oh, we're going to call this a structural measure," and so that's why we call it a structural measure.
I see. Can you give an example specifically?
Yeah. So the structural components of this is just the foundational pieces of the people at the hospital are organized into a team, basically. And there's a leader of the team or a committee, a multidisciplinary committee that really oversees the older adult initiatives within that hospital. So that's the structural part. It's not, I think that a lot of people think of maybe we need to hire a whole bunch of people and so forth. It's not that at all. It's taking the people who are there and organizing it into a team that's going to function. And then with that team, either does, depending on the size of the hospital, or helps to support, oversees the different processes, the frailty assessment, the ensuring goals, and the shared decision making, and so forth. And we think that obviously the way the Donna Beatty model works, as you know, is that with the structures in place, that you can do the processes, doing the right processes well, you get to the outcomes. So that's how we design the measure.
And that makes sense. So essentially you're including sort of leadership in age-friendly care.
Yeah. Yes.
Interesting. So how does it affect? And so this is in effect right now.
Yes.
As we speak, this is happening.
So yes, the measure, right as we speak, the measure began in the it is in the IQR, the Inpatient Quality Reporting program of CMS. It is an attestation measure, so hospitals attest to it. And so it is for this year that the hospitals are participating with this.
Exciting. So how do you think the measure the attestation of the measure will ultimately affect operations? What are essentially, what are the major changes that hospitals are going to make to implement this?
Yeah, I think that, as I visit hospitals, or the hospitals that I work in, what this does, it gives a list of things that the hospital should focus in on. So it's not the scores, there's no compliance data, it's not a rate or anything like that, but it lets hospitals know to focus in on the goals, the medications, the frailty screening. And so in surgery, it's very important that we screen for frailty before an operation, so that we know if there are things we need to do before the operation to prepare the patient for the operation, and then even post-operatively, and so forth. And so even in a relatively straightforward operative case, if a patient has a lot of comorbidities and the frailty screens positive, then there are a lot of things that we probably need to do before and after the surgery, even though the operation itself might be very straightforward. And so there's a number of things that the measure identifies that a hospital knows, like, oh, these things are important. We should really address these things. And so I think that's probably one of the most important parts of the measure. It'll like a number of things, when hospitals have to figure out they need to do something, they usually try to do it as efficiently as possible, and that's usually ends up in standardization. So instead of one off, or like you have 10 different teams doing it 10 different ways, just standardize it across the hospital and figuring out that's where the leadership and kind of the structural pieces come into play. Like, well, for our hospital, maybe this is the best way to do it, and we should all agree to do it this way rather than the one-off way. And I think that's for hospitals, and what we've seen at the college, this works with all of our other kind of quality programs, is that there's a programmatic initiative of the hospital. And we think it's really important that, especially with the expanding and aging population in our country, that having a programmatic view of older adult care is really important. And if a hospital doesn't have it, that they should really start kind of planning and kind of embedding it into their care.
Right. I couldn't agree with you more that seems critical as we're moving forward. Have you gotten any, is there any sense that this is particularly burdensome for some hospitals?
Yeah, I think that it really depends on where the hospital's starting from. If they've never thought about these things before, it's, thinking about, 5 different domains of new things can be,
Right.
it's new and have to deal with it. Probably, the goals are, the living wills and the proxies and so forth. That's probably in hospitals already. So it's probably a tweak rather than developing a new thing. Medications in all hospitals, we were kind of having all the stuff that we're doing with medications. And now it's just a step further to see that, all right, there are probably some medications we should not use in older adults. And it's going to have untoward effects, or there's going to be incongruences when we put all these medications together. So it's just one added step of just like doing what we do, but doing a little more and doing it better. The frailty stuff, I think that, hospitals, we know that frailty is, at least in surgery, it is there probably 25% of the time post-op. We know that frailty, when it occurs, it aligns with increased complications, increased length of stay, increased readmissions. And so it is a factor in a lot of the metrics that we look at already. And so if we're not already working on it, we should be working on it. Social vulnerability is probably, in certain kind of teams in the hospital, a relatively new thing, but we know increasingly more, and your work is really major in this, that we really need to pay attention to that. Having the patient come from their setting, having the patient come to the hospital and whatever care they get, and then going back to the setting, there's a lot of things that we really need to pay attention to really optimize the care that we're giving for this person, this human being who is an older adult, and there's things we need to really pay attention to. And so for hospitals that have not thought about these, it might be, but hopefully hospitals have thought about these.
Right.
And
Right.
it's just building on, as we all do, just improving every single day and addressing more things that are important.
Yeah, well, as you alluded to, I am very interested in the social vulnerability component of this work. And, I study, a lot of patients with dementia, many who live alone. Surprisingly, it is a large population, many who we often think of as unrepresented. They actually don't have family around. This is an increasing concern demographically. Many who are homebound until they're sort of come in for some emergency. How is the hospital going to address this? Like, this is an issue that's really challenging when this happens. And so how, is this the hospital's responsibility? And I'm asking it in sort of a just fun way, because I get to ask you the questions stuff, but like, really, how can we address these big challenges, let alone simply like, okay, let's, not that it's simple, helping them get Medicaid, or isolation, or the caregiver stress that we know can be rampant in populations.
Yeah, and I wish I had a great answer for you. I don't. But this is one of the issues that I think that by putting it into the measure and shining some light on it and putting attention to it, it's better than, where it's been in the dark
Yeah.
largely. And so a number, as I said before, when we did the work in the College of Surgeons to develop what we were doing in surgery, a number of, the two things that we heard most were that goals are so important, and the surgeons can think one thing, but you have to hear from the patient what their goals are, and what they want, and how, their health, their life goals, their health goals, their kind of this hospitalization, this procedure, their goals, and then the social vulnerability issues. And so shining a light on that, I think, will help to uncover some problems, challenges, and also probably some opportunities that we can move forward with. But it's clearly a big issue in that as we get to these social vulnerabilities, we need more than just the medical model to address those. We need a
Right.
social model that embeds, aligns, overlaps, works together with the medical model to really address these things.
Agreed. So from the perspective of a family, from the consumer perspective, and patients and caregivers too, what do you think they're going to notice? Will they see anything different, and what kinds of things will they experience?
Yeah, what we really designed the measure to do is to, let me step back. Quality, the domains of quality, the steep domains, the safety, timeliness, effectiveness, efficiency, equity, and patient-centered. We really designed this with the help of all of the stakeholders involved and all of these experts involved to be all of those, but really focus on patient-centeredness. And that recognizing that the older adults, from one to the next, their goals are very different. Their level of comorbidities and disease is perhaps something that, is unique in the setting. There's levels of complexity where complexity is not just a whole bunch of things going on that are sometimes very difficult, but it's that unpredictability of these things meshing together. And what type of system do we have in place to address that unpredictability? So our experience at the College of Surgeons, when we deal with highly complex situations like trauma care, we don't know what's coming in the ER, through the ER into the trauma service. You wake up and you're just like, I wonder what's going to happen today. But they have set up a system where they have structure, process, and outcomes. And the College of Surgeons oversees the trauma program in the country. All the level 1 trauma centers are basically verified, accredited by the College of Surgeons, but they do it the same way. Structural pieces, process pieces of when a patient comes in, what is done, and then outcome metrics to kind of make the whole Donna-Beedian model. And so in the complexity and unpredictability in the trauma setting is not unlike the complexity and unpredictability in taking care of older adults. And it is that piece of having standardization, but the being kind of agile, flexible enough to take care of these folks in so doing. So when you ask what the patient and the family can expect, is hopefully what we're trying to set up is the patient-centeredness, that if a patient comes in and, I'm a colorectal surgeon, and a patient the other day came in and has a very early stage colon cancer, that's, yeah, I can take it out. But the patient has a lot of comorbidities, and patient that was in her 90s and said she didn't want it out. And that, her life expectancy was consistent with, what her wishes were, and those were her wishes. And she knew the risks and the pros and cons. And we both decided, like, okay, yeah, we'll follow it. If it becomes symptomatic, we might have a discussion again, but we'll kind of go forward with this. And so it became very patient-centered, because, usually if somebody has a cancer, we really try to treat the cancer, take it out, but it's very patient-centered. So I think that is one thing. What matters to the patient, just like in that example, and hopefully efficient. Sometimes, I think that especially with our care now, we're having longer waiting lists. We're having, duplication of tests and so forth. And hopefully this will be much more organized at the hospital level, and then subsequently more efficient.
Let's hope so in this way, right?
All right, here's some wood I'm knocking.
I know we all should be, and I think the intent is a good one, right? In terms of what we want. What do you think the implications would be for hospital staff as they're working?
Yeah, I think it's kind of those same things as we said before, is that having something programmatically really helps hospitals. So if there is, a program for trauma or a program for cancer, there's some level of organization of people know who work there, like what happens. This is what happens when a patient comes in with this diagnosis and this, or this symptom of the diagnosis, or this sequelae of the diagnosis. And having an organizational way of doing things helps the workers in a hospital, helps the hospital itself. So I think that having a programmatic view of older adults based on these things, kind of in chronology, is the goals, the frailty issues of going through, the medications as they go through, of what they come in on, what they might be on in the hospital, how they get discharged, the social vulnerabilities of that. Caregivers is a huge issue in this country, in the world. And how does that fit into that? And I think that the structural pieces of the measure are supposed to help kind of organize that, so that within the hospital, that hopefully everyone's rowing in the same direction at the same speed, rather than just like you make it up as you go. No more flying by the seat of our pants in this. It's really is
Right.
really kind of getting everything together.
Like we're no longer assuming that everyone sees that our population is aging and that there are some unique needs. Now we're sort of requiring somewhat of a structural change so that people can address appropriately, but with, as you say, some agility in the
Yes.
process.
Yeah.
Do you think smaller hospitals will have issues because of this relative to larger healthcare systems?
Yeah, I think that's, there's always benefits and disadvantage of being small and being large. Um, Large hospitals have to kind of coordinate a lot of things. Smaller hospitals, sometimes it's easier to get done, but then smaller hospitals might have less breadth, whereas
Mhm.
larger hospitals have a larger breadth. So, I mean, regardless of what a hospital has, an older adult walking in the door needing care is going to need care. These domains of this measure are going to be important regardless of the size of the hospital. And I'm a firm believer of in the implementation science aspect of context. The success of things is within the context of a local setting, and having a single facility understanding what it can and can't do
Mhm.
as it addresses the goals and meds and whatever is going to be really, really important. Um, a lot of times we like to have like a one size fits all, and I think that most of us know that that usually does not work.
Right.
It's really kind of, yes, you see one, and the most important one to see is the one that we're working in.
So I know it's only May, but how's it going? It's early in the process, but do you have any sense of how it's going so far? Any, successes and maybe some challenges?
So I think that you know, when people see measures that have a lot of pieces like this, the first kind of reaction is like, oh my God, yet more things to do.
Right.
Um, yeah, that's human nature. So how we have tried to really address this is that one of the problems we constantly hear about, and I think that probably everyone on this Zoom, this will resonate with them, is that we kind of feel like we have a foot in two canoes. So we have a foot in the canoe of like we're trying to give great care to every single patient we kind of are taking care of, who comes in the door, and we're trying to do the right thing by the patient. The other canoe is kind of all the regulatory, the measures that we have to comply with. I mean, the great study that came out of Hopkins of hundreds of measures and costing millions of dollars to kind of address all those things. It's like there's and it's hard to keep a foot in two canoes and kind of stay afloat. Um, the obvious answer for what everyone says, like, well, why can't we just align these things? And what we've tried to do with this measure is to align this. These are the
Mhm.
really important things that, whether it's a measure or not, these things should be done. And so it's really kind of bringing these things together, that if you are, for an older adult, addressing their goals and the meds and all the different domains of this measure, that is really what you should be doing for care. And that was kind of attesting to these things to the measure. So it is really trying to bring those canoes back to one thing, overlapping of the right thing to do, and that is also the measure. I think that what we've seen is that, so I'll talk now just about the American College of Surgeons. We have a number of quality programs, again, based on this structure,
Mhm.
process, outcomes framework, and that it works. And so the trauma program has been in existence for decades. And if somebody is injured, they want to go to a verified trauma center rather than, a non-verified trauma center. It has lower complications, lower mortality, people do better. We have a cancer program, same thing. Cancer, there's better process of compliance, there's better survival, and so forth. And so this idea is sets it up in a way that it helps hospitals to not just comply with the measure, but to really give the care that we all want to give. We hear that as soon as people, as hospitals really understand that this is the things that they should be doing, it becomes clear that, yeah, we need to lean into this. And so that messaging is very important. If there's a message that people get from this, is that leaning into this measure is going to be a great thing for your hospital and the patients that come to your hospital. We have, if I can go on just for a couple more minutes, that we have a program at the American College of Surgeons that really addresses older adults. It's called GSV, Geriatric Surgery Verification Program, and it's largely aligns with these measures. We kind of built it we built the measure from that program, and it does these things. And so hospitals that have done this already, I gave the example of delirium. There's a hospital system in upstate New York that has really worked on delirium and has decreased their rates of delirium. They have, and the benefits have been decreased length of stay, decreased readmission, decreased complications. The revenue has increased because the beds are opening up and they can bring more people in. So that's great, but the care is better because of these. And so there's a number of other examples of that, but we know this works. The message is to lean in.
Yeah. So I have a few more questions still, but I just want to remind listeners that they can add their Q&A in to the question and answers, and we will get to those as well. But I guess what's important that I just want to make sure you review for us is, so how is CMS monitoring compliance? How does it work?
Yeah, so there is this is an attestation measure. So hospitals, in the same way as some of the other inpatient quality reporting measures are attestation. There's a patient safety measure currently and others. It is in the same way. The data will go to CMS, and then it will be reported on one of their public sites. I think the following year or the year after that. There's a delay for them to get the data and then report it.
So in about a year, we would see it,
I
potentially
think
the end of the year.
it's in that time
Are
frame.
there other plans for evaluation on individual sites or anything that we could expect?
Not through CMS. I think, from the College of Surgeons, we have this program in older adult surgery, geriatric surgery verification, and we help hospitals. We help to evaluate how they're doing, what they're doing, but I don't think through CMS as of yet.
Okay. So one other thought is, like, this is great in terms of this hospital measure, but what are your sort of hopes for continuing to think about age-friendly health systems in general? So, I try to keep everyone out of the hospital relative to thinking about older adults with comorbidities and serious illness. So in terms of community-based care or other types of health care services.
Yeah, I think that, so this measure, as you've kind of pointed out, is really in the inpatient setting. There's a lot of care undertaken, given, delivered in the outpatient ambulatory setting, and really expanding this into those areas as well is probably one of the most important next steps. We have, and a number of smart people have discussed this with CMS of how to expand it, and I think that is, people can look forward to really addressing these things outside the hospital in the future.
Okay, so that's likely underway, or we're going to sort of see this first and then recognize that there's more to be done, essentially. Okay, well, what I'm going to do now is turn to some of the questions that we've received and give you, share that with you. I think first there's a question around sort of what the screening tools are that are supposed to be used, and sort of who's responsible for the frailty screening. Are there recommendations for what should be used?
Yeah, so there are a number of different screens, and we left it open. The idea of, from all the experts said, leave it open, because some will like this one, some will like that one. Some hospitals like this one, some hospitals like that one. It's hard to be very specific on these. And so that is left open. But the important part is that there's a screen that is done. So things like cognitive impairments, for those types of issues. Screening physical function is very important. Screening their for malnutrition and so forth. And part of that domain is also that if there's a positive screen, having a plan in place for what is going to happen. In surgery, as an example, as I said, that when we screen for frailty, and if there's a positive screen for something, do we need to do something before we take the patient to the operating room for an operation? Do we strengthen them up? Do we increase their nutrition, or do we go straight to the OR? So that is a really important piece. And having these protocols in place so that it's a standardized way to do it is going to be so helpful, I think, for patients when we start to really standardize how we screen for the patients for frailty.
But, you know, sort of the example you gave of sort of we screen, we recognize they're frail, and without, like, then what? You know, we don't, you know, sort of what is required, or what, you know, if we're not making that standardized, right? We're allowing them to sort of work. What if they have no solution, or no resources, or no geriatric team? You know, what is to be done?
Yeah, so great question. Very early on when we were designing all this and discussing it, the AGS, American Geriatric Society, said, all right, there's not enough geriatricians for all the work
Right.
that you want to do. So now what? And so, you know, the idea is that we figure out what are the right things to do, and then individuals to do it. And so does it have to be a geriatrician to do the frailty assessment? No. Does it have to be a geriatrician to kind of understand what is going on at the site and what the protocol should be if they screen positive on a cognitive for cognitive impairment? Well, if there is a protocol in place that is put out by geriatric experts, then can those be followed? And I think that through the American College of Surgeons has these protocols in place so that when there's a positive screen, there are things that can be followed. And I think that CMS is also developing these educational tools for the hospitals to put those into play. And then it is as I said, the individual hospital figuring out, all right, this is how we're going to do things here. This is how we're going to standardize things here. This is what we can do commensurate with the patients that we see, with the kind of the resources that we have, with the expertise we have in place here, and move forward with that. And what this is providing is just that menu of things, that and having the local place deciding what from the menu that to put into play into their local setting.
So just related to that, there's a comment here that I think is really relevant. A concern of mine, based on clients and the literature, is that patients who are obviously incapable of self-care are sent home without support or at any attempt at an alternative placement. So it sounds like this is really working to address that.
Yeah, I mean, I think that the social vulnerability domain is a hugely, I mean, they're all important. That one is probably newer to a lot of settings than the others, and needs really to be respected and addressed, because those types of things that the questioner brought up are happening, but that's clearly not good care. We need to do better.
Well, it does seem that, you know, there's so much of it that, again, this is a hospital setting we're focusing on. And in terms of, we sort of need the connection with ambulatory and community-based care. And, you know, I am very interested in home-based care too. And I guess sort of, it seems like there needs to be discussion with those groups now, right? Like, not ready for, like, let's roll this out inpatient, then we'll, you know, because it's all connected.
Yeah.
Certainly from the patient and family perspective.
Yeah. Yeah. Well, yes. And just in the way things unveiled for this, it happened to be inpatient. Would it have been better to kind of revamp the whole system? Yes, but kind of when we get to this idea of validity versus feasibility, we're just like, all right, we have to kind of weigh some things towards the feasibility piece first, and just start where we start and then expand from there. And so that's, I think we have.
I think that's fair.
we have our work cut out for us.
Right.
But we're at least, I think we know what this work is right in front of us versus just it's still under the rug or under the hood.
And another question from our audience is how is the population defined? Is it just by age 65 and over?
Yes. Medicare, it's a Medicare measure, so it's 65 and older.
Okay. And I guess there's some interest in the eliciting patient healthcare goals component. How is that interacting with palliative care expertise? Are there specific requirements to track living wills, advanced directives, as a resource, et cetera? And I know there's variation, of course, everywhere around that.
Yes. So there's living wills, the proxies, advanced directives, it's all those. But a lot of times the living wills and the advanced directives are not absolutely focusing on the goals of, for example, that hospitalization, or how aggressive or not aggressive, or what, and how does that align with their health goals and life goals and so forth. And so this is beyond the advanced directives and living wills pieces. It really gets more into details of what the patient wants, kind of for what their hospitalization is now. And because it can and probably will affect the type of hospitalization or the decisions made. And so that's a really important piece of just of kind of getting the goals of in a more detailed way for the more acute situation.
And there is a interest in where we can find the full measure document. So I'm hoping that's something we can share with all participants after this.
Yes, you know what? I will find it on the CMS website and share it with everybody. Otherwise, the College of Surgeons has a version of it, but probably best to get it from CMS.
I agree. And I think that will be nice for people to review. And there's just really a couple of comments that I want to raise that, people are really excited about social vulnerability domain, especially focusing on caregiving and caregiver burden. And I guess, how is this perceived of as just sort of family caregivers? Is there any interest in including other types of cares? I'm assuming paid caregivers, home attendants, sort of how are they really considering any
Yeah, I mean, I think that it is the whole piece. And the amount of caregiving done by the whole package is huge. The amount of caregiving by family members who are not paid is huge. I mean, I heard a figure in the billions of dollars of unreimbursed, unpaid for caregiver care that occurs in this country, and that brings about a whole set of challenges and problems in that. The health of the caregiver, the stress on that caregiver,
including financial stress.
Yeah, absolutely. All of these different stresses, economic and so forth. A lot of times for older adults, the caregiver is another older adult. And so there are just, it really needs to be addressed. And so on the one hand, it brings forth challenges. On the other hand, we are very happy that it was in this measure, so that it kind of shines a light on it, that we really need to address these things.
Yeah, I agree. I'll give you a real hard one, but I will have to ask is, do you anticipate any changes to the measure under new CMS leadership?
Yeah, I haven't heard anything about that. Having said that, I think that all measures need to be revised. All measures need to be revised at some point when we have new information, see what the landscape looks like. Some need to be sunset, some need to be expanded, some need to be just revised. And so I haven't heard anything. This just got released, just as you said, several months ago. So I haven't heard anything yet, but wait and see.
Wait and see. Fair. And there's a couple questions related to the role of nursing in the development of these measures and implementation. And can you speak to what nurse leadership involvement, since it does seem like a lot of this will be handled via nurses, in terms of their role in the hospital system, having most patient and family interaction.
Yeah. So I don't know if it's a majority, but it was a huge amount of input into developing these measures from the American College of Surgeons side was with nurse input. So both in terms of validity and feasibility, a lot of times, as you said, that who kind of makes these things work a lot of times, and it's as nurses, and what's the feasibility of making this work in the implementation piece of kind of at the front lines. Everyone has a lot of things to do. And, how does this happen on top of a lot of things to do? And so this measure was developed in a way that to make it, again, to use those two words, both valid, evidenced and expert based and feasible. So it can be done, and it's not an inordinate amount of list. The list of things that could be done that we probably should be, the wish list is huge, but it was really taking the best of the best to kind of start with and putting it into this measure. We definitely heard from the nurses that, how do we implement this? Is this so important? Are these the things that are the first order things to do? And so in working with them, we came up with these
Great.
domains of the measure.
Great to hear that. And I have another question that I think is really important is, what advice do you have for patients and caregivers who are coming to the hospital? Like, what should they ask for at this point in time?
Yeah, so I think that when the very first domain is goals, and that it's highlighted that, yeah, we should really elicit the patient goals. That requires a patient to know their goals, or to really kind of be able to discuss their goals. And I know that, I hear from a lot of folks on the care side that the geriatricians and so forth, that it helps when people think about their goals beforehand, and thoughtfully. And so I think that there's a lot of things in preparation for those things. It's like, well, what do I want? And so that is really important, because a lot of things are derived from that very first step.
Right. So, and again, just for the audience, get your questions in now, because we're almost done and there's a lot of interest here and a lot of great questions coming in. I'm going to give you, I think, a challenging question, but I think you can handle it, Cliff. There seems to be a disconnect between age-friendly health systems and hospital efforts, as well as the age-friendly communities or public health efforts. So how do you think hospitals can better address age-friendly care transitions and really bridge what we already talked about, sort of the medical care model with the social care model? And are there opportunities for social prescribing, for example? And also, just to highlight the dementia population, which is fairly relevant here, are there opportunities for integrating with the guide model, which is also, hot off the presses as well? So what are opportunities really for partnership?
Yeah, so as you know, as probably most everyone on the call knows, that working in silos has benefits, but usually has a lot of disadvantages. And one of the disadvantages is that when we work just, for example, in the hospital, and we kind of have our blinders on to what's outside the hospital, that's going to hurt the system eventually. And this piece here is starting to open up the doors to doing that with the social vulnerability, and it's kind of opening up the it's going beyond the medical model to increase the social
Right.
model. It'll probably go into, a lot of quality improvement is not just the scientific model, but it's the psychologic behavioral science model of like, well, why should I do improvement, and whatnot. It's choices of engagement and leaning in. So I think that one of the overarching goals of this is really opening up the eyes of just these different kind of silos to these issues, because the idea of taking care of an older adult is much more than what we do in the hospitals, much more the operation that I do in the operating room. But if we're trying to fulfill our kind of ultimate goal of quality of life and kind of and that aspect for the individual patient, it's going to have to break down those walls of the silos. And we always hear about like, oh, we're going to break down the walls of the silos in our organization and in our community, and it's sounds so great, and the napkin drawing looks so amazing, but in real life, how do we make that feasible? I think that this measure is starting to do that, but it is one tiny measure in the inpatient setting in a attestation measure. And so a
Right.
lot of work really needs to be done with that. And so, and you highlight the dementia issue, which is a huge issue that we need to deal with in the world.
Yeah.
And bringing that forth in this is, it's a piece of this, but it really needs to be, there's a lot of things in this that need to be expanded in subsequent work. This
Yeah.
is a toe in the water. And
Right.
so
Well, I don't want you to downplay this. Is, exciting, but it's important to acknowledge sort of there's a larger system that this touches. And I think it's great in terms of, focusing on social vulnerability, as you said, and really eliciting the patient's goals. Like that's a pretty big deal. It's sort of a change, to really start with that.
yeah,
I want to
absolutely.
ask a question from the audience that I think is really important, and they're moving around on me, but really getting at sort of what can we do to sort of make sure that this happens, that CMS continues, retains this measure and moves it out more broadly, right, to become an outcome measure, or really thinking about it, from a primary care perspective or sort of a larger perspective. Is there anything that we can do as a community to support that and, sort of help with this incredible effort?
So well, thank you for that question, because I think the more support for this area, the better. We all know that this is an issue. We all have parents or older neighbors and friends and so forth, and uh, that who really we want them to have good care, and regardless of whether it's inpatient or in the out or whatnot. CMS has a lot of opening kind of public comment things, and so those are I know they take those very seriously, all the public comments. And with that, I hate to sound like an advocacy person, but I know that also your person in Congress listens to this. If it's a issue in their district, in their region, that they will listen to the people in their region, because that's what they do. I think for us at the College of Surgeons, we love hearing about what works, what doesn't work, what we missed, what we need to revise, and so forth. And because we're always, as are the other kind of partners in this measure, trying to make this thing better. The measures coming out, I think, will have this ability to have much better data as we get more and more automation of our data, as we get more interoperability of our data, as we get more details in the data. The measures that have been difficult, whether it's with a data collector or not as detailed because they're coded ICD codes and so forth, I think that will get better sooner than we think. And as soon as we have better information, we will be able to better evaluate the care that we're giving and improve on those things. We'll have better and metrics, and we'll have better ways to do things. So I am very optimistic that quality overall will get better and quality in the older adults will get better.
Well, I appreciate that optimism. We all need that. So thank you so much. There are other questions. I'm sorry we didn't get to everything today, but I want to turn it back over to Ellen for some announcements and logistics.
Again, many thanks to Dr. Ornstein and Dr. Coe, and thanks to our audience for joining us. You can find all of our age-friendly health content, including Health Affairs Journal and Forefront articles, podcast episodes, and virtual events on our website, healthaffairs.org. We have several more virtual events coming up in the near future for Health Affairs Insiders. As you can see, this Thursday, May 29th, is a Health Affairs Insider event on the FDA's first 100 days under the second Trump administration. That's from 1 to 2 p.m. Eastern Time. On Tuesday, June 17th, will be an insider event on breaking down risk adjustment trends and potential reform at 2 p.m. Eastern. On Wednesday, July 9th, we will have our annual Supreme Court wrap-up event for insiders at 1 p.m. Eastern. And we recently released our first trend report for Health Affairs Insiders on artificial intelligence in healthcare. So if you're not already an insider, you can find out how to become one so that you can access these types of events and trend reports and more at healthaffairs.org/insider. Thanks again, everyone. We are now adjourned.